Sir, we are live and you can start.
So good evening. Thanks for joining. This is Dr. Ashish Prasad from the medical team of USC. Welcome to this product theater on Dapagliflozin. We are fortunate to have these two important speakers today, Dr. Abhay Sahu and Dr. RITESH AGRAWALA, who will be taking us through the important aspects of Dapagliflozin. Before Dr. Abhay Sahu starts the presentation on Dapagliflozin, I'll share a short introduction of Dr. Sahu. Dr. Sahu is the MD in Medicine and DM Endocrinology from AIIMS. He is Professor of Endocrinology, Department of Endocrinology and Metabolism, IMS and SCM Hospital, Bhubaneswar. He is the Organizing Secretary of SCCon 2018 and SCCon 2012. He was the Co-Organizing Secretary of SCCon 2015 and 2017. He is a recipient of the prestigious Rajdhani Gaurav and Ekam Rashtriya Award. He has been invited as guest faculty to various national and international conferences. He has been part of 8 national and 7 international publications and has written many chapters in different books. With this brief introduction, I hand over to Dr. Sahu. Over to you, sir.
Thank you, Dr. Ashish. So today we'll discuss about particularly the clinical current updates and impacts on the clinical practice with Dapagliflozin. So, yeah. So we'll discuss the topic on the heading of SGLT2 inhibitors, changing landscape for treatment of diabetes. What are the Dapagliflozin's metabolic effect, and what are the studies, cardiorenal outcome trials like TIMI 58, DAPA-HF study and DAPA-CKD study, and what is the difference between DAPA versus Remogliflozin, what are the approved indications, and what are the take-home messages from the particularly topic. So SGLT2 inhibitors are the changing landscape for particular treatment of diabetes. People see the SGLT2 inhibitors are relatively new class of particularly anti-hyperglycemic agents for management of type 2 diabetes. And we know everybody the mechanism of action. It reduces the reabsorption of glucose in kidneys. It facilitates its excretion in urine by inhibiting particularly this high capacity SGLT2 located in the proximal convoluted tubule, and thereby lowering the glucose level independent of insulin action. Recent trials have demonstrated there is a significant cardiovascular and renal benefits of SGLT2 that resulted in a paradigm shift in management of diabetes. And we everybody know in 2019 and 20 we'll see all sort of guidelines. Again, even if before metformin, after lifestyle, even if before metformin, if all sort of ASCVD risk factors are there, if someone is having microalbuminuria, CKD, SGLT2 has been placed. Even if before metformin, one can directly go to SGLT2, even if starting prior to metformin. Coming to the Dapagliflozin, among this SGLT2, Dapagliflozin is weak. India, mainly 3 important gliflozins are available. One is Empagliflozin, Dapagliflozin, and Canagliflozin. And of course, one Indianized gliflozin, Remogliflozin is there. And DAPA is a SGLT2 inhibitor that is approved for treatment of type 2 diabetes in almost all countries or European countries, US, India, everywhere it's available. It is a highly potent and a reversible SGLT2 inhibitors, having more than 1400 times more selectivity toward SGLT2 than SGLT1. It is the main transporter which is responsible for glucose absorption in the gut. And Dapagliflozin induced this glucosis in patients of type 2 diabetes is associated with a significant calorie loss. We know the patient on any sort of gliflozin, there is a weight loss of 3 to 4 kg. And this moderate reduction of body weight, majority time this weight loss is due to loss of fat, not the lean body mass. And this mild osmotic diuresis can lead to also a transient natriuresis initially, but on continuous use, there is no natriuresis, or usually the body becomes a balancing state, which leads to actually no further sodium loss. And there, of course, a moderate decrease in the blood pressure. We know initially there is some sort of decrease in circulatory volume because of these diuretic or natriuretic properties of the drug. But in the latter phase itself has actually, there is reduced in particularly this sympathetic tone is reduced. Also, there is some sort of vasodilatory effect in the periphery that leads to actually minimal reduction in the blood pressure among those group of patients. If we see the glycemic control, then there are numerous randomized double-blind multicentric phase 3 trials with DAPA as a monotherapy or in combination therapy has been there. And we have some real-world evidence data like CBD Real 1, 2, 3. They have given clear-cut in lakhs of people. They have given a significant judgment that Dapagliflozin is one of the drug which has a significant better control, not only for the glycemic control point of view, also whatever that RCTs has given for particularly cardiovascular point of view, renal point of view, same thing it also has been replicated in the real world evidence data. So the reducing body weight and blood pressure in a broad spectrum of patient of type 2 diabetes, that including those with high baseline HbA1c, even if more than 9, and even if elderly people, those who are more than 65, this drug can be safely used. But you have to be a little bit cautious when you are using in elderly population. And this is the cardiorenal protection mechanism overview. You will see SGLT2 inhibitors, they at one side, they cause natriuresis and also glycosuria. And this glycosuria leads to actually weight loss along with good glycemic control. And this natriuresis has 3 important factors. It causes some sort of lowering of the blood pressure. This glomerular tubular feedback is inhibited, and also there occurs amelioration or decrease in the volume overload. And this tubuloglomerular feedback is one of the important factors which causes intraglomerular pressure reduction. And all those things actually, these things actually has good effect, particularly from the renal point of view, also good effect from the cardiovascular point of view. Again, there are certain additional factors or mechanism through which actually it causes some sort of renal protection, which is the reduces oxidative stress, reduces fibrosis induction, it reduces local inflammation, reduces tubular senescence, also reduces glomerular damage. All those things again give some sort of possible mechanism or plausible mechanism for protection of the kidney point of view. And there are certain landmark trials, outcome trials. You will see the first one is particularly declared TIMI 58, and the trial design is taken almost 17,160 type 2 diabetic patients, and there are 2 groups, those who have been established CV disease, taken close to 600, 974 patients, and those who are having multiple risk factors, there are additional 10,180 patients were taken in that, and there is a randomized 1:1 double blind, and then one group DAPA is there, and another group is placebo is there, and that it is an event-driven study. At least more than 1,390 events should be done or should be there to end the study or to make the study powerful or to make the study powerful. And there is a median age follow-up up to 4.2 years. And the safety is the mesh they try to from the mesh like cardiovascular disease, microinfarction, ischemic stroke. Also for dual efficacy, CVDA, hospitalization due to heart failure, and 3-point mesh. They try to see that. And if you see the baseline characteristics, it is almost mean age is 64, and almost 37% are female, and almost all continents, North America, Europe, Latin America, Asian Pacific, everywhere patient has been taken. 40% people have established CVD, and baseline HbA1c is 8.3%. And the baseline eGFR in particularly this declared TIMI is 85. That means majority people have normal GFR, and patients were on other drugs. Any sort of people think metformin, insulin, sulfonylurea, DP4, GLP-1, shift agonists, everything. There again, other drugs like ancillary drugs like antiplatelet drugs, ARBs, beta blockers, ACE inhibitors, they are also, some of the people are with this along with statins. And what they found in the Dapagliflozin group, if you will see the CVD and hospitalization due to heart failure together, then the hazard ratio is 0.83. That means there is a 17% reduction with DAPA group in comparison to placebo. And again, the superiority testing P value is 0.005. Again, it shows it is superior for particularly CVD and heart failure combined together. If you will see the 3-point mesh, the hazard ratio is 0.97. That is only 7% reduction. And P for non-inferiority is statistically significant, but P for superiority is not significant. So there is 3-point mesh reduction is there, but it is not found to be superior. But non-inferiority has significantly. If you see the secondary endpoints like first renal composite endpoint, a 40% reduction in GFR or ESRD or renal or CVD was found in the DAPA group in comparison to the placebo with a statistical significant p-value with a hazard ratio of 0.76. That means a significant improvement is there. And if you see the all-cause mortality, again, the hazard ratio is 0.93 with a p-value of 0.02. That means it is actually, for the superiority point of view, it is not found to be superior. So if you are summarizing the declared TIMI, if someone is having a prior history of microinfarction, then the DAPA gives benefit of 3-point base, CVD, hospitalization due to heart failure, renal failure, everything is there. If someone has just a prior MI, then again, MACE 3-point base, CVD and heart failure, renal, every benefit is there. But if someone is having particularly ACVD, no prior MI, or for primary prevention purpose, you are not getting the benefit of MACE. But of course, from the cardiovascular disease or hospitalization due to heart failure, and renal benefit is still there for ACVD risk factors alone without any events, also for the primary prevention point of view. Let's discuss about the DAPA heart failure. The beauty of DAPA heart failure is that almost a good number of people are there having non-diabetic. So when Dapagliflozin was first initially started, it was started as an anti-diabetic drug. But this is the study which is showing that a lot of the people having non-diabetic are also included in the study. And usually inclusion criteria is NIOH class 2 to 4, ejection fraction less than 40%, or pro-BNP more than 600 picogram per ml. And exclusion criteria GFR less than 35. And if systolic blood pressure is significant low, like less than 95, or patient is type 1 diabetes. And here, they want here to make the study powerful, at least 844 events should be there. And the composite endpoint is CV death, hospitalization due to heart failure, or urgent heart failure visit. And there are a lot of visits, and also 1:1 randomization were there in the study. And you see that almost the mean age in both diabetic and non-diabetic group is almost same, and both diabetic and non-diabetic group is almost matched in majority of the things. Blood pressure, ischemic etiology, whatever maybe you discuss, almost majority part it is almost matched. So here diabetic is 2100 people are diabetic, whereas non-diabetic is 2600 people. And patients were all other treatments like diuretics, ACE inhibitor, or ARB or ARNI, then beta blockers. Then additional like ICD, CRT, also some of the people are there. So they were all included in the study population. So what they found, those who are diabetic, the hazard ratio for CV death, hospitalization due to heart failure, or urgent heart failure visit, if you take together, then hazard ratio 0.75. In diabetic, there is 25% reduction is there with Dapagliflozin. Whereas those who are non-diabetic, the hazard ratio again is further low, that means 0.73. That is a 27% reduction in non-diabetic population altogether combined. But if you take only CV death and hospitalization due to heart failure, then again same thing was replicated among the diabetic. The hazard ratio is 0.75, and non-diabetic is 0.73. Similar thing is actually there. And if we see the all-cause death in the diabetic, then actually the hazard ratio is 0.78, and in the non-diabetic it is hazard ratio 0.88. That means again in the diabetic all-cause death, in the diabetes there is 22% reduction, and in non-diabetic population there is 12% reduction with Dapagliflozin in comparison to the placebo group. So what they concluded, among the patients with heart failure, a reduction in ejection fraction, those who received Dapagliflozin has a lower risk of worsening heart failure or death from cardiovascular causes and better symptom scores than those who are receiving placebo. And this benefit was regardless of presence or absence of diabetes. That is the beauty, that after this study, Dapagliflozin was actually approved for use in heart failure patients, even if in the non-diabetic patients. So based on this DAPA heart failure, US FDA has approved DAPA to reduce the risk of CV death or heart failure hospitalization patients with heart failure, with reduced ejection fraction, with and without type 2 diabetic patients. So let's see the DAPA CKD patient. CKD is the one of the clinical trial. Here actually almost 386 centers in 21 countries, 4,304 patients were randomized in a double-blind placebo-controlled trial. At one group, it is actually DAPA, received DAPA 10 milligram, and matching placebo and still was given in the opposite group. And inclusion criteria is those more than 18 years of age, GFR between 25 to 75, urine albumin creatine ratio between 200 to 5,000, and patient is already on a stable tolerated maximal dose of ACE inhibitor or ARB for more than 4 weeks. And exclusion criteria is type 1 diabetes, those having polycystic kidney, lupus nephritis or ANCA-associated vasculitis, and also patient is on immunosuppressive therapy, they were excluded from the study. What they found, if you see the primary outcome, there is a more than 50% GFR sustained, more than 50% eGFR reduction or ESKD or renal or CV death. In the placebo group, there are 312 events, and DAPA group, it is 197 events. So NNT is 19, and p-value is very much strongly significant with hazard ratio of 0.61. That is almost a 39% reduction in the DAPA group in comparison to the placebo group. And if you will see the summary of primary outcome, if you will see the more than 50% eGFR decline, in the DAPA group, it is very much significant. Again, among the ESKD group, eGFR less than 15 ml, it is significant, but less than particularly more than 50% GFR. Those who are on chronic dialysis, again, they are getting benefit. But from the renal death and also transplant point of view, actually, it is not studied. And for the CV death point of view, again, it is giving significant benefit, having those already on CKD. And if you see the secondary outcome, that is sustained more than 50% eGFR decline or ESKD or renal death. In particularly the DAPA group, it is 200, placebo group, it is 243 events, whereas in DAPA group with 142 events with hazard ratio of 0.56. That means almost a 44% reduction in DAPA number of events in the DAPA group in comparison to the placebo group. So a significant improvement in particular renal outcome in comparison to the placebo group. So in patients with CKD, with and without type 2 diabetes, this use of Dapagliflozin compared to placebo significantly. That is reducing the risk of renal failure, reduces the risk of CV death and heart failure hospitalization. Also, it prolongs the survival of the patients. Now let us compare our own Indianized gliflozin, Remogliflozin, which is available in India, probably in India only, and of course South Korea and also Japan are probably some of the places where it is available. But DAPA is not like that. If you see the global presence, it is almost Dapagliflozin is present everywhere in the world, whereas Remo is available only in India and probably in South Korea. Approved indication, it is glycemic control. Now it is heart failure with reduced ejection fraction. Again, with DAPA CKD, you can get also those who are having diabetic or non-diabetic, having proteinuria, or to reduce the particularly renal events, you can use Dapagliflozin. But where Remo is only for the glycemic control. And if you see what are the heart failure and DAPA CKD are the major landmark trials with us, but with Remo, there is nothing is there. If you see the strength of evidence, that is 1419 results in PubMed, whereas in Remogliflozin, there is only 29 results. And if you see the dosage frequency, it is once daily, whereas for the Remogliflozin, again, you have to go for twice daily dosing. So DAPA has been approved indications by DCGI in adults aged more than 18 years or older for type 2 diabetic mellitus to improve the glycemic control. And again, adults for treatment of heart failure with reduced ejection fraction. These are the indications by DCGI. DCGI has been actually approved in India for its use. So, finishing my talk with this take-home message: Dapagliflozin lowers the glucose level independent of insulin action. It provides effective glycemic control and also reduces the blood weight and blood pressure. It reduces the risk of worsening of heart failure and death from the CV causes. It reduces the progression of renal disease, lower risk of hypoglycemia. It is highly cost effective. Hence, it should be a part of the therapeutic regimen for all eligible type 2 diabetic patients. Thank you.
Thank you, Dr. Sahu, for the excellent presentation. Now I would like to invite Dr. RITESH AGRAWALA for his presentation on the pharmacoeconomic edge of Dapagliflozin. I'll just give a short introduction of Dr. AGRAWALA. Dr. AGRAWALA is MD Medicine and DMA Endocrinology. He is the eminent endocrinologist from Odisha. He is currently the consultant endocrinologist at Amri Hospital, Bhubaneswar. He is known for his relentless efforts in and contribution to the field of diabetes and thyroid disorders. He has 10 publications in international and national journals. He has received the first prize in oral presentation at the Assam Endocrine Conference. He's also received the first prize in poster at SECON Odisha State Chapter. With this introduction, I hand over to Dr. AGRAWALA for his talk on Dapagliflozin from Economic Edge. Over to you, sir.
Yeah, thank you, Ashish. Can you please allow me to share my screen? Yeah, it's okay now. So good evening all. After the Dapagliflozin come to the market with a less and cost-effective price, the role of pharmacoeconomics menace in diabetes in India has come up. So cost-effective age of Dapagliflozin, and my parts, most of the 50% of the part already said by Dr. Abhay, where he had explained the role of Dapagliflozin, how is it beneficial in the management of type 2 diabetes, and how it is comparable with the Indian's Remogliflozin. So Dapagliflozin is little bit of more superiority in terms of data, in terms of effectiveness, in terms of the outcome, in terms of cardiovascular outcome trial. So when the cost effectiveness is an issue, we also know the ADA 2019 and 2020 guidelines also. When we individualize a patient, the cost effectiveness is a concern while treating a group of type 2 diabetes patient. So the pharmacoeconomics gives us idea about the treatment of any case where the low cost medicine is required for the prolonged period of time, which will improve the compliance of the patient and also increase the adherence to the molecule by the patient. So this is a picture where the pharmaceutical company came up with a pill that cures everything, but I am warning you, it's gonna to be expensive. So it is here to decide which molecule is better for our patient and what is the cost of the molecule to give the same outcome. If two molecules with the huge cost differences are there and come up with the same outcome, it is us to decide which molecule to prescribe to our patient to get the maximum benefit. So when you come to India, which is come out to be a diabetes capital, and in 2020 or 2050, it must be crossing China in the prevalence of diabetes. So management of diabetes in India is a major issue, and cost of treatment in India, we have to take care because it increase the adherence with increase the effectiveness of the molecule if the molecule will be prescribed for a prolonged time. So in India, the annual expenditure by the patient on a diabetes care is an average of 10,000 in urban area and 6,000 rupees in rural area. And this also found in several studies that lower income groups spent a larger proportion of their income on diabetes care. And urban population spends more in absolute term and also in their complications. And 89% of the patients use their household income to fund the monitoring and treatment of their diabetes. So we have to take care while prescribing, especially drug therapy to our patient to decrease the pill burden and to decrease the cost of the therapy. When you see the state-wise in India, the per capita GDP and the prevalence of diabetes, the Bihar, Meghalaya, from Chandigarh, Tamil Nadu and Delhi, the number of per capita GDP increase, the prevalence of diabetes is also increasing. That means the prevalence of diabetes is more toward the urban area and more toward the high GDP state. And the maximum number of diabetes care cascade in India, if you diagnose 100% diabetic, 50% are aware about the disease and 50% are not aware what is diabetes is. In the awareness group, if you treat the patients, only 42% receive treatment, 58% not. And in the same group also, sugar is controlled in only 25% and uncontrolled in 75%. So a lot of causes are postulated why the people are not controlled even after the treatment, maybe because of the cost of the therapy, the compliance and adherence to the molecule is poor. And because of the cost of the comorbid condition, the compliances are also poor. So we have to take care of the cost of the therapy part while treating a patient with type 2 diabetes or any form of chronic disease in day-to-day practice. So the diabetes related attitude and the practice in India, if you see the frequency of distribution of attitude toward management of diabetes, doctor reported diabetes only 30%, 70% are still now unrecognized. Insulin intake, 70% didn't take insulin or do not wish to take insulin. Here it is a good part that diabetes pill intakes are much more. Home test awareness is 50% and blood glucose home test are only 8% of the patients are doing. 92% of the patients are not doing. And in a diabetes costly disease, in India, if you study, the average expenditure per patient per year would be around 4,500. So if you think in a country like India where 8 crore diabetic patients are there, on an average of 8 lakh rupees they will spend in a 20-year time of treatment of diabetes. So where the cost come from? Either it is the medical cost or the comorbid association complication cost or the non-medical cost. What are the medical cost? It is the anti-diabetic molecule, the laboratory cost or the cost of the physician and nurses. Comorbid condition, it is the micro and macrovascular complication or any emergency leads to hospitalization. Non-medical cost are the cost of transportation, work loss day, cost experienced by caregiver during the hospitalization. So in India, a study where they found that the anti-diabetic agent cost around 86% of their total cost, followed by the laboratory charges, followed by the physician charges. So almost all the cost spent for the diabetes management are the anti-diabetic agent. So if it is possible to give a cost-effective molecule with the same outcome in terms of cardiovascular safety, in terms of renal safety, in terms of hospitalization for heart safety, or any other or the durability of the, if the cost-effective molecule is there, then definitely a patient will get the benefit and the adherence and compliance will be more. Here you see in a study where the evaluation of pharmacoeconomics direct cost in diabetic patient, it is the comorbid condition like retinopathy, nephropathy, and neuropathy, most commonly the neuropathy, and the cost, total cost in isolated diabetes mellitus associated with peripheral neuropathy and other comorbid condition. So more the number of comorbid condition, more is the cost expenditure for the patient to manage the comorbid condition and glycemia. In 2016, the annual cost of illness of diabetes care per patient, if you see diabetes without complication, with complication, with dialysis, and with cardiac intervention, the cost has drastically increased in diabetes without complication of 22,000 per year to around 1,66,000 those who have complications with cardiac event. In 2017, also the cost has increased much. Direct cost, which include the cost of dialysis, cost of medication, cost of investigation, AV fistula charges, indirect cost for cost of lost wages, cost of transportation. In all, there is a increase on an average of 24,000, and the number of dialysis required are 7.27 per month, and number of drugs per day is around 7 to 8 number of drugs patients are taking, according to the study in the St. John's, Bangalore. So why the cost is important for our patient? Because out-of-pocket expense, no insurance protection is there and no insurance penetration in our society. Maximum number of patients coming from the rural India, so they are not aware. They are poor farmer and laborer, and high cost leads to the poor medical adherence, as I have told earlier. So in Diabetes Care India, Dr. Joshi et al. Also published that considering the high cost incurred at various steps of screening, diagnosis, monitoring, and management, it is important to realize the cost-effective measure of diabetes care that are necessary to implement, because these are the disease which are the chronic disease which require lifelong treatment, and cost-effective therapy definitely increase the adherence and compliance to the molecule, and we have to take care of the outcome of the molecule. Not only the cost is an issue, but the effectiveness, the safety profile, and all should be taken care with low cost, definitely gives a good outcome in the management of type 2 diabetes. So as we are discussing, we all know the benefit of SGLT2 inhibitor in last 2 to 3 years, how the cardiovascular outcome trial both in diabetic and non-diabetic cases, how it will give benefit, And already Dr. Sahu has explained the role of this SGLT2 inhibitor by saying about the different landmark trial associated with dapagliflozin. So we know the dapagliflozin definitely gives the glycemic benefit with weight loss, reduce hospitalization for heart failure and CV death, 3-point MACE with CVD and severe risk factor is reduced and shows renal protection. So value of event of 1 hospitalization for heart failure, 1 myocardial infarction and 1 stroke is definitely gives a better outcome. So when you compare this dapagliflozin, which is now available in India with a low cost compared to the innovator, because we are not only concerned about the cost of the molecule, we are also concerned about the outcome of the molecule. If the molecule is low cost but is not effective or has some side effects, it is not beneficial to our patient. So if you compare the cost of the dapagliflozin compared to the innovator, the cost is around 15 rupees per tablet compared to 56 rupees per tablet, that is the innovator brand. Per month, it is costing around 450 rupees compared to 1600. And per year cost is around 5,000 rupees compared to 20,000. So a patient is going to save around 15,000 rupees per annum with this low cost dapagliflozin. And this cost effectiveness analysis, it not only analyze the money part, but also analyze the effectiveness. As I have told, it reduce the blood sugar level and cost effective and most commonly applied form of economic analysis in the literature, especially in the drug therapy. Already the dapagliflozin and remogliflozin compared with compared by the Dr. Sahu in terms of its efficacy, in terms of its safety profile, in terms of its cost, in terms of the frequency of giving this molecule. But when to come to the cost, now pharmaceuticals companies are also saying remogliflozin is low cost, but when you compare the existing dapagliflozin, the cost per tablet is around 15 rupees, remogliflozin is 25 rupees. Again, over a period of 6 months, patients are going to save around 1,000 rupees. Decrease in fasting plasma glucose is more with dapagliflozin. Decrease in HbA1c is almost more with the dapagliflozin R. And when you see the decrease in weight, decrease in blood pressure, all are little bit of higher with the dapagliflozin R, along with the less cost, along with the more evidences are available for the dapagliflozin. So as I have earlier also said, the benefit we are planning for our patient is not only based on the cost of the therapy, but quality adjusted life here is also important, and quality of the molecule, outcome of the molecule, we have to take care by selecting the molecule. So cost is J part in pharmacoeconomics and value of pharmaceuticals like quality adjusted life year. So both are balanced to give a pharmacoeconomics molecule to our patient with low cost, with maximum benefit to utilize the limited resources, whatever available in our country. So this is the pharmacoeconomics where cost is in a part and the efficacy, medical outcome and the complication in a part. So we have to balance both the arm to give the maximum benefit to our patient with the limited resources. So the cost utility analysis, if you see in terms of the renal event, myocardial infarction or stroke, heart failure event, quality of life of hospitalization or life year, here the period of clinical trial, the probability of survival is there. Estimate over a period of exceeding the clinical trial and efficacy and safety. So when you compare the dapagliflozin over the remogliflozin, even though the cost is little bit higher with the remogliflozin, but strong evidences are there available with the dapagliflozin in terms of renal event, in terms of myocardial infarction, in terms of heart failure, in terms of quality of life for hospitalization and life failure. Excuse me. So as I have told, cost along with the strong evidence gives dapagliflozin at the upper end in terms of remogliflozin and other SGLT2 inhibitor available. So if I combine all the SGLT2 inhibitor along with the newer low cost dapagliflozin in terms of best cost effectiveness, best STO utility, when you see the cost effectiveness wise, again, Dapagliflozin is a little bit of superiority in terms of REMO-R. When the renal event is there, more data are available with the Dapagliflozin. So best cost effectiveness and best assured utility is there with the Dapagliflozin R. When you see the myocardial infarction and stroke rates, especially Dr. Sahu has also told those who have prior history of myocardial infarction, they are get maximum benefit with the Dapagliflozin, and there is no cardiovascular outcome trial available with the Remogliflozin. Heart failure event, the cost and the best assured utility is there with the Dapagliflozin R. Quality of life is maintained with the low cost Dapagliflozin. Life year is extended, and when you compare all the SGLT2 inhibitor which is available, that is the innovator Kana, EMPA and DAPA, which comes as the low cost effectiveness because the cost is very high, so they have a best assured quality. So only the recent Dapagliflozin with low cost, they have a best cost effectiveness, best assured utility, and I think this is the ideal drug for the mass drug treatment for all. So the take-home message from my side, for our country like India, the total annual expenditure by patient on diabetes care is very high and majorly funded by household income. So we have to take care of the cost. Economy of diabetes is controlled by direct and indirect cost. Direct cost is the medical cost, drug cost, and the healthcare cost. Indirect cost is the transportation cost, holiday cost, and the job loss cost. Significant glycemic control, weight loss, and cardiovascular benefit of SGLT2 inhibitor we already know, which makes this class as the most suitable drug of choice in management of type 2 diabetes. Dapagliflozin has shown upper edge in cost-effective analysis, cost minimization analysis, and cost utility analysis as compared to innovator and other SGLT2 inhibitors such as Remogliflozin in the management of type 2 diabetes. So earlier also I said, we are not only seeing the cost of the molecule, we are also seeing the utility analysis, that is the effectiveness, outcome, and the same parameter in terms of cardiovascular, renal, myocardial infarction outcome. So if you combine low cost with the maximum outcome, definitely that will be the best molecule to prescribe in our day-to-day practice. Thank you for your patience here. So over to Ashish.
Thank you, Dr. Ritesh, for the excellent presentation. It was very good. You explained so well. I'm sure the audience must have learned something new today. And I'd like to thank both our speakers, Dr. Abhay Kumar Sahu and Dr. RITESH AGRAWALA, for the excellent presentations. I'm sure the audiences have now learned a few, got new insights on the use of Dapagliflozin in their practice. With this, I also like to thank the audience for joining in for this presentation. Thank you so much. Stay safe and stay healthy. Thank you, sir.
Thank you.
Thank you.